Assalamualaikum and very good morning. Welcome to the 6th Emergency Medicine Seminar Series, Week 2 Clinical Toxinology, a collaborative webinar series jointly organized by Universiti Kebangsaan Malaysia, Universitas Brawijaya, and the University of the Philippines, along with our esteemed partners. My name is Muhammad Ilman from the Department of Emergency Medicine, Hospital Chancellor Tuanku Mukris, and I will be your moderator today. Before we begin, let me briefly walk you through today's tentative schedule. We will begin with 3 presentations. First, Dr. Choo Kim Hoon will speak on the cardiotoxicity in Naja species bite. Following this, Dr. Allan Dionisio will present on Ciguatera fish poisoning. Finally, Dr. Zainubun will discuss the effect of magic mushroom psilocybin in Indonesian adult male. After the presentation, we will have a forum and Q&A sessions where you can ask our experts your questions. During the break, I will also introduce an exciting upcoming event, APMT 2024, the 22nd Scientific Congress of the Asia Pacific Association of Medical Toxicology, which will be held in Penang this upcoming November. After the Q&A session, we will conclude with a Kahoot quiz where you can test your knowledge in an interactive way, followed by some closing remarks. Now, a few housekeeping announcements before we begin. First, kindly post your questions in the Q&A session. Questions will be answered in the forum session after all presentations. The feedback form will be available at the end of the webinar and will remain open until 3 p.m. local time. Please fill in and submit the feedback form to receive your e-certificate and claim your CBD point. The Kahoot winner can message Dr. Winnie for prize information. Thank you for your attention. Let's now move on to our first session. It is my pleasure to introduce our first speaker, Dr. Choo Kim Hoon, an emergency physician from Sarawak General Hospital, Malaysia. Dr. Choo is currently a trainee in a clinical toxicology subspecialty program. He has extensive experience in managing toxicology cases and has been actively involved in organizing workshops and training on toxicology across Malaysia. His contribution to emergency medicine and medical education is highly recognized. Today, Dr. Choo will share his knowledge on cardiotoxicity in Naja species bite. Please welcome Dr. Choo Kim Hoon.
Hi, good morning, everyone. Thank you for your kind introduction, Dr. Ilman. Thank you for inviting me to give a talk in this Congress webinar today morning. I will proceed with my topic today. Will be about cardiotoxicity in Naja species bite in our country, Malaysia, because there are different cobra species throughout the whole world. But today I will be talking mainly about the Naja species in Malaysia. Okay. So before we go into the detail about Naja species bite in Malaysia, first just a bit of introduction of the snacks of medical significance in our country. So basically, we can divide snakes into 2 main groups. It's a venomous and non-venomous. So in Malaysia, the venomous snakes that can be found in our surroundings are mainly Viperidae, Elapidae, Natricidae. And for non-venomous, is our python, and others are non-colubrid. So for viper is pit viper. This is Malayan pit viper. There are other green pit viper and not green pit viper. There are other pit viper like Bornean pit viper, Cameroon pit viper, Highland pit viper, etc. in our country. But the most famous one will be our Malayan pit viper. Then for Elapidae, there are 4 different species, which includes cobra. This is cobra, crab, sea snakes, and also the coral snake. For Natricidae, majority of Natricidae are non-venomous, but there is 1 species in this group is venomous, which is the redneck quillbacks. So for pythons, I think everyone is familiar. This is our famous reticulated python, which is the skin is very beautiful. Then for Colubridae, there are all other non-venomous snakes that commonly found around us, like this. So go to a bit of numbers. Throughout the 5-year spans, from 2010 to 2014, there are a total of close to 16,000 snakebite cases that have been reported. Of course, I'm sure there are a lot of cases that are unreported. So this number actually is a bit underestimate due to underreporting. And the number of deaths over the same period is only 16, averaging around 3 to 4 deaths per year. If we change into percentage, actually it's just less than 0.01%. But this is just about mortality. The main problem about snakebite is not only about mortality, it is also about the discapacitation caused by the snakebite, like the limb is affected and need to go through wound debridement, and maybe the scar healing is not so well, and infection. So all these are morbidity. So the morbidity information is not so completely recorded as well. So the data is not so complete. Then throughout the snakebite, that these 16,000 cases, we found that the northern part of Peninsular Malaysia has more cases compared to southern region of Peninsular Malaysia. So these are just now the 5 groups that we will go through the effects of the venomous snake in Malaysia. First, the cobra we can see is mainly local symptom due to cytotoxicity, neurotoxicity is a post-synaptic, and cardiotoxicity. For crab, is slightly similar to cobra, but it is also neurotoxicity, but there is no cardiotoxicity, and most of the time there is not much local symptoms. It may even cause no local symptoms, but with significant neurotoxicity. For sea snake, it's similar to crab with the extra effect of myotoxicity. It can lead to rhabdomyolysis. For coral snake, also have local symptoms, neurotoxicity and myotoxicity, but the effects are less strong compared to the other 3. For viper, it's mainly over the coagulopathy and also local symptoms, hematotoxic and local symptoms. So Malaysia is home to 2 cobra species, namely Naja cautia and Naja sumatrana. And from the available report, we found that the Naja sumatrana bites is more than Naja cautia bite, most probably because of the distinct geographical distribution. Like this is the Naja cautia. As we can see here, the region is mostly over the northern region, a bit to the central on the west coast, but the distinctive feature is there's a monocle over the hood, or over the dorsum region of the snake. But for Naja sumatrana, we can see it can be found throughout the whole Malaysia, including Singapore actually. So it can be found throughout the whole Malaysia. So there is most probably the region that the number of cases is more due to Naja sumatrana bite. And we can see from the picture, there is no monocle over the hood. And so this is the most distinctive feature. And from the name itself of Sumatran spitting cobra, it is the main culprit that cause venom ophthalmia in our country. It can spit the venom directly to the eyes and cause venom ophthalmia. So this is data that produced by our FRIM Forestry Malaysia and published in a bulletin in Conservation Malaysia. It's a data over the 3 years of number of venomous snakebite in Malaysia. So we can see here the green color is the number of cases caused by Naja sumatrana, and the red color is the number of bites caused by Naja cautia. So from here we can see the Naja sumatrana is significantly much higher compared to the rest of the snakes. So before we go into details about how cobra cause venom, as we know that just now I said the cobra is mainly causing local symptoms, neurotoxic and cardiotoxic, but how is this so? So before we go into it, we will understand it through the cobra venom composition. So the cobra venom is composed mainly of enzymatic and non-enzymatic components. The enzymatic components are mainly phospholipase A2, a lot of proteases, hyaluronidase, amino acid oxidase and nucleotidases. The main subgroup of the enzymatic component is the phospholipase A2. For non-enzymatic, the main component is three-finger toxins, and three-finger toxins include neurotoxin, cytotoxin, and cardiotoxin. And cardiotoxin is actually a subtype of cytotoxin. So for the enzymatic component, it mainly just function like our enzyme in our body, other enzyme in the body. It catalyzes some specific biochemical reaction resulting in cellular breakdown and cell damage. And it also works synergistically with the non-enzymatic component to cause the ovotoxicity of the cobra venom. So for the three-finger toxin, the name itself is so because from the structure, you can see it's just give some imagination. It looks a bit like three finger. The three finger, 1, 2, 3. So it's like a three finger. That's how it is named as a three-finger toxin. So the cobra venom is rich in three-finger toxin, and but different species will have different amount of toxin, and even within the same species depends on the geographical distribution and also the food that the snacks is feed on. It can have different amount of the three-finger toxin as well. But generally speaking, Naja cautia, we have around 50 to 70% of the venom protein is contributed by three-finger toxin, but in Naja sumatrana is 40 to 60%. And as mentioned just now, it can be either the three-finger toxin include neurotoxin, cytotoxin, and cardiotoxin. The most lethal one will be the neurotoxin, which is alpha neurotoxin. It can be the long chain or short chain, but the main culprit here will be the long chain neurotoxin. So for cytotoxin, as the name implies, it's called cytotoxicity. It means that it affects the cell. It will cause cell damage and cell lysis. And it can target various types of cell, including our skin. That is the reason why it can cause dermal necrosis if you get bitten by the cobra. And if it involves the heart cell, then it is the subtype that is named as cardiotoxin. But because these two are interrelated, so in some case report or journal article that you found online, you will see that they interchangeably use these two terms, cytotoxin and cardiotoxin. So before we go into detail on it, then generally the cardiotoxic of snake bite is poorly understood because there are not much data on it, and the frequency of cardiotoxicity due to snake bite is also the cases are also not many. So because of not much information is involved, then it's difficult to estimate the incidence as well. We cannot say how many % of the patient bitten will have likelihood to have cardiotoxicity. It's difficult to estimate it because the number of cases reported is very low. So generally speaking, not only for cobra, but venom proteins and peptides can act in different way. So their effect on the heart can be cardiotoxic or cardioprotective. So some of the ACE inhibitor are actually they found from the snake venom because of the bradykinin potentiating peptides. So this act on our angiotensin renin angiotensin system. So the main compound will be, as mentioned, the bradykinin potentiating peptides, cardiotoxin, phospholipase A2, and natriuretic. But not all the snack contain this compound. Different species contain different components. Some may just contain cardiotoxin, some may just contain bradykinin potentiating peptides. So generally, throughout the whole case report that can be found online and other articles, the cardiovascular effect that have been reported include hypotension, MI, cardiac arrest, hypertension, brady or tachycardia, and cardiac arrhythmias, including AF. So the causes, as mentioned, because the data is lacking, so can only be hypothesized with multiple mechanisms, which include toxin-induced coronary spasm. Then for certain snacks, it can upregulate the coagulopathy and cause thrombosis. So it becomes thrombotic microangiopathy and cause the damage. The arrhythmias can also be induced directly by the toxin, direct damage to the myocardial cell, myocyte, inflammation due to venous hypersensitivity, and some is, for example, C-SNAC can cause rhabdomyolysis and renal failure, resulting in hyperkalemia, causing cardiovascular effect. So all these are the mechanisms that have been hypothesized, but how about the cobra in Malaysia? So there are no exact study that has been done about cardiotoxicity due to cobra bite in Malaysia, but from the available report and study done on other species, then and see the components of venom proteins that can be found in our cobra as well. We found that the three-finger toxin and phospholipid A2, these two are actually in our cobra. And from the study of other similar genus, other Naja, the effects is mainly on the cell, for the three-finger toxin, which is the cardiotoxin and self-toxin, is mainly on the cell membrane, adrenergic receptor, and cholinergic receptor. It suppresses the heart contractility. And for the phospholipase A2, which is the enzymatic component, it can cause direct cardiotoxicity because it's a pro-inflammatory component. Remember, the phospholipase A2 is our body pro-inflammatory pathway. It's the first step before it go into the cyclooxygenase pathway. So it can cause direct cell injury. So it also can cause direct cardiac injury. At the same time, it can reduce the myocardial contracture also and cause some vasodilation. So all these are the combination effects of the cobra venom of Malaysia, which means it's the Naja cautia and or Naja sumatrana. So now we know a bit of the pathophysio. So how about the management? So in Malaysia, we does not produce our own antivenom. So this antivenom, we rely heavily on the supply from Thailand, the Queen Salvaba Memorial Institute production of the antivenom. So for the Naja species, we are using the monospecific Naja cautia antivenom, and they are already been proven in study that is able to cross-neutralize Naja sumatrana venom. And the efficacy against Naja sumatrana venom is comparable to that against Naja cautia venom. But all this study was done to test the neurotoxicity, mainly the neurotoxicity. So how about cardiotoxicity? There are actually no study done for cardiotoxicity because the frequency of cardiotoxicity also is rare, and there are other reasons also we'll explain later. So before we go into that, I will discuss a case first, then we will go into detail about how to manage the cardiotoxicity due to cobra envenomation. So this is a real case that happened last year. It's a 14-year-old boy. He was bitten over the left index finger while trying to capture the snake. The snake was at the location actually is by the beach. So I'm not sure why the snake was at the beach, the Naja sumatrana, and the snake is actually just lying there. From what the boy say is, he saw the snake lying there, he thought the snake is dead, so he tried to catch it. So after the snake bite him, his friend killed the snake and called the family to bring the child to the hospital. So it arrived at hospital around 1.5 hours post-bite. So on arrival, there is only complaint of mild local pain. The pain score is 4, and we noticed some mild swelling over the left index finger. But when we check the vital sign, the BP is slightly high. It's 149/83, but the heart rate is the one that shows something to us. It's only 45 to 55, which is bradycardic. So immediately we put on cardiac monitor and we show PVC. So we proceed with an ECG. So this is the snake that bite him. Initially just lying on the beach. Then the boy go kacau him and bitten and killed the snake. So the wound, we can see here the wound with the black arrow is a very small puncture wound. There's not much of local sign. There's no dermal necrosis. The swelling over the left index finger also is very mild. So this is the ECG, which was done 30 minutes after arrival, which means that it's around 2 hours post-bite. So there is multiple PVC that can be seen with bradycardia. So at this point of time, at that point, we are still not sure whether we want to proceed with antivenom or not because the patient only has no symptoms. Although the ECG show multiple PVC, but the patient did not complain of any chest symptoms. There's no giddiness, there's no angina, no SOB. no chest discomfort, etc. There's no, the child is actually asymptomatic, only complaint of mild pain over the left index finger. So we are not sure whether we need to give the antivenom or not, but 30 minutes later, the answer is out because 30 minutes later, the boy started to have left eye ptosis. Why only left eye unilateral? Most probably because it's still very early before it developed into bilateral ptosis. So we know what to do at this point. We administered our the QSMI and KAV according to our Malaysia guideline, which is 10 vials, and complete within 1 hour. And this is the result 2 hours post antivenom. The PVC disappeared. The bradycardia slightly improved. Maybe the baseline is already 55 to 60. And the ptosis also resolved. So the diagnosis is Naja sumatrana bite over left index finger with systemic envenomation, which is cardiotoxicity and neurotoxicity. But to think further, what if there's only cardiotoxicity? Let's say the child developed the multiple PVC and there's no neurotoxicity at all after that. So should we give the antivenom? So before we go into it, we try to see why this case they have a cardiotoxicity first. So there have been multiple case report about Naja species bite, not just the Naja cautia and Naja sumatrana, just all type of Naja species in the whole world that can be found in PubMed. That there have been case report resulting in neurotoxicity and cardiotoxicity, which manifests as severe hypertension, tachycardia, heart block, VT, and even VF. But however, in this case reports, the neurotoxicity always precedes cardiac complication. So the indication to administer antivenom is very clear because the neurotoxicity already appeared. So and why is this so that the neurotoxicity always precedes cardiac toxicity? Because there's one study about Naja sumatrana venom of the Thailand and Malaysia species in rabbits, and they found that the main neurotoxin, cardiotoxin, and the enzymatic component of phospholipase A2, they found that neurotoxin is rapidly absorbed and has the highest systemic bioavailability. But the cardiotoxin, although is rapidly absorbed, but it has lower systemic bioavailability. And most of the time, it stays localized at the injection site. So that is the reason why there is a thermal necrosis due to cytotoxicity. And phospholipase A2 is lower absorption, low systemic bioavailability, and stay localized at the injection site. So this can explain why most of the time the patient will have local envenomation, which is shown by thermal necrosis, and neurotoxicity if due to the cobra venom. And cardiotoxicity is somewhat relatively rare because the cardiotoxin, which also cytotoxin, usually most of them will be stay localized at the injection site. But in this case, in the case that I presented now, somehow it released to become systemic circulation and reach the heart and has the cardiotoxicity. But there is a reason why medicine is never 100%. This is just a general saying. So to that, there is only one case report that demonstrates ventricular bite jam without neurotoxicity from Naja species bite, and is published by Prof. Khaldun. It's a case in Malaysia. It's a ventricular bite jam following a cobra venom. So in this case, only 1 vial of NKAV was administered, and after that, the ECG resolved. So if in the future we see cardiotoxicity, how should we approach and how should we administer the antivenom? Until today, there is no study being conducted to measure the efficacy of the antivenoms against cardiotoxicity. But we can try to derive some information from studies conducted towards cytotoxicity. Because cardiotoxin is a subset of cytotoxin, so we can use the study conducted towards cytotoxicity to help us to understand more. So there was a study published in 2022 conducted to investigate the cytotoxic activities using a rodent fibroblast cell line. So in this study, it's done in Malaysia combined with Thailand. So they're using the QSMI and KAV to try to investigate the efficacy towards Naja cautia and Naja sumatrana cytotoxic effects. So if it's found that it's effective in neutralizing the cytotoxicity from Naja caudia envenomation, but it only shows limited neutralization activity against the Naja sumatrana venom induced cytotoxicity. So why is this so? One of the reason, of course, because it's a monovalent, monospecific. It is specific towards Naja caudia, so of course it will be more effective towards Naja caudia. But there's another reason also. They found that they actually have different type of cytotoxin. Naja caudia venom contains mainly S-type cytotoxin, but Naja sumatrana is containing the P-type cytotoxin. So when they compare these two types of cytotoxin, they found that the P-type cytotoxin produce stronger effect than S-type, not only locally, but also towards the heart. It can result in faster blockage of the heart when they test it on a red heart muscle. So this may explain that in our case, which is bitten by Naja sumatrana, it has cardiac manifestation. So, and when investigating the antivenom towards the cytotoxicity, not only because of the cytotoxin type is different, but they found that it can also be due to the different type of phospholipase A2 that is present inside the Naja sumatrana venom. So they found that the effect of the NKAV towards the Naja sumatrana phospholipase A2 is not so much compared to that of Naja caudia. So this diagram is from another study that actually they compare the C-SNAC venom and Naja caudia monovalent antivenom, but just concentrate on the Naja caudia part. We can see from here that the CTS1 is the S-type and CTS2 is the P-type. So you can see from the arrow, the neutralizing potency is the highest with blue arrow. So it's to the long chain neurotoxin, and also the S-type neurotoxin. That is the reason why it is effective against Naja caudia cytotoxic effect. But the green arrow is less effective. So it's not so effective towards cytotoxin, P-type cytotoxin. So this can be one of the contributing factor that this antivenom is not so effective against the cytotoxic together with cardiotoxic effect of Naja sumatrana. So this about it. So what is the answer towards the case? If let's say you saw a case like just now, but it doesn't have any neurotoxicity, should we give the antivenom and how much to give? Okay, there is no proper answer because there is no proven efficacy and dose regime of NKV towards cardiotoxicity per se, only induced by Naja envenomation in Malaysia. But having said that, my personal opinion will be, this is still a type of systemic envenomation. So for systemic envenomation, we will still follow the Malaysia Ministry of Health guideline. I will advise to give, as per the guideline, to give a 10 vials NKAV. So in the future, how to improve? For the data collection part, maybe we should include ECG findings, especially Naja species spikes. If we can get the ECG picture and interpretation by expert, that will be even better to improve our study quality, the data collection quality. And since we know that the antivenom, the QSMI NKV is not very effective against the cytotoxin 2, which is the P-type cytotoxin. So maybe there will be improvement in the antivenom neutralization potency against this cytotoxin in the future. And maybe we can do some lab study to find out the dosage recommended. And if we can find the dosage, maybe the early antivenom administration can potentially prevent neuroparalysis in cases similar to the case I presented just now. If the patient presents early with cardiotoxicity without neurotoxicity, maybe the early administration can help to prevent the neurotoxic effect. So the take-home message is always have high index of suspicion for cardiotoxicity, especially you are managing Naja species spike. because although it's very rare, but it can happen. Then if it's Naja species bites, it's better that for the early stage, we put on cardiac monitor with serial monitoring and also serial ECG to help us to determine the timing of giving the antivenom. Then the occurrence of ECG finding is important. It can be early indicator, but don't forget other causes of arrhythmias. In the case that I presented and the other ventricular bigeminy cases published, both the patients were young and previously healthy, so they have no other causes of cardiac disease. But in some patients, like elderly patient, they might have other potential causes of cardiac arrhythmias. So we need to rule out that before we say the cardiac arrhythmias is due to the SNAC envenomation. So that's all for my presentation. Thank you. These are my reference.
Thank you so much, Dr. Choo, for that insightful presentation. Sorry. Before we move on to the next presentation, a quick reminder, please post any questions you may have that in the Q&A section. We will address them during the forum Q&A session. Thank you so much, Dr. Choo. We will meet again during the forum session.
Okay, thank you.
Now, I would like to introduce our next speaker, Dr. Allan Dionisio from the University of the Philippines. Dr. Dionisio is a clinical toxicologist and family medicine consultant with over 2 decades of experience in both fields. He has served as the head of the toxicology section at the Medical City General Hospital and continues to be involved with the National Poison Management and Control Center in the Philippines. He is also a well-regarded professor and author. Today, Dr. Dionisio will talk about Ciguatera fish poisoning, a significant marine toxin affecting both clinical practice and public health. Please join me in welcoming Dr. Allan Dionisio.
So good day to everyone who is here listening to the Emergency Medicine series. And thank you to the organizers of this series for inviting me to be able to talk about Ciguatera fish poisoning. Now, Ciguatera fish poisoning is an entity that isn't often talked about, but it can be a considerable problem in the future, as we shall see. Now, if you have a patient who ingested a big reef fish, who develops afterwards paresthesias and myalgia and gastroenteritis, then think of Ciguatera fish poisoning. Now, Ciguatera is a strange name and requires a little explanation. This is a picture of the turban shell. And the Portuguese sailors back in the 1500s who first experienced the symptoms of Ciguatera fish poisoning thought that the turban shell was the reason why they developed these symptoms. But they were mistaken. It was actually the reef fish that they had ingested and not the turban shell. However, the name stuck, hence Ciguatera fish poisoning. Now, notice, I'd like to emphasize now that we're talking here about reef fish, not ocean-going fish, but rather reef fish. And later on, we will see how these fish became toxic and its connection to the reef. A little epidemiology. Ciguatera fish poisoning is endemic in tropical and subtropical waters throughout the world. However, because of worldwide trade, it is possible for toxic fish to end up in places where they are not usually found. Like, for example, in France, there was a case of Ciguatera fish poisoning because of ingestion of fish coming from the Philippines. There are 50,000 to 500,000 cases globally every year, and I'd like to emphasize that term known, okay, because unfortunately, there is severe underreporting of these cases. A lot of the victims are often people who live in coastal communities where they often don't go to doctors, though they don't go to hospitals, and therefore their cases don't get reported. Fortunately, the mortality is low at 1%. And then there are a few cases, a very unfortunate few, where the symptoms, usually the symptoms last for just a few days, but for this small subset of patients, the symptoms may last for weeks to months and sometimes years. And we're going to go back to this subset of patients later. Now, here in this study by Chan back in 2015, he identified the countries where there were reports of Ciguatera fish poisoning. And if the country is pictured in orange, then those are the countries where there are reported cases. However, just because the country is in pink, okay, doesn't necessarily mean that there were no Ciguatera cases there. Again, because of severe underreporting, then it is possible that there were Ciguatera cases, but they were just not reported in the scientific literature on which Chan based his study. Now, exactly what kind of big reef fish are we talking about? Okay. Some of the common vectors for Ciguatera fish poisoning are the snappers, okay, or family Ludgenidae, the groupers, or family Serranidae, the emperors, or the emperor breams from the Lathrinidae family, barracuda, and moray eel. Now, notice these are all big carnivorous fish. However, there are actually many possible fish vectors. In some outbreaks, even herbivorous fish, not just carnivorous fish, were initially involved. But generally, we're talking about large carnivores associated with the fish. So the bigger the fish, the greater the association with Ciguatera. Now, how do the fish become poisonous? It begins with damaged or dead coral because of natural causes or because of human activity. Corals die, and then these dead corals are taken over or colonized by algae, by certain leafy algae, and these algae are subsequently colonized by dinoflagellates, which produce the toxin that causes Ciguatera fish poisoning. The herbivorous fish graze on these dinoflagellates that have colonized the algae, that have colonized the dead coral. And the carnivorous fish are in turn eaten, the herbivorous fish are in turn eaten by the carnivorous fish, which are eaten by larger carnivorous fish, which eventually are eaten by humans. And that is how we develop the symptoms of Ciguatera fish poisoning. So there is bioaccumulation of the toxin throughout the food chain, such that the biggest fish are oftentimes the most toxic ones. This is Gamberdiscus toxicus, which was the first dinoflagellate that was identified as being a vector for Ciguatera fish poisoning. And if you notice here, you have the Gamberdiscus toxicus that has colonized one of the strands of algae on the dead coral. It was named Gamberdiscus because it was first identified in the Gambier Islands. However, since then, there are other genera of dinoflagellates that have also been identified as producing the toxin that causes this condition. Fukuyoa, Amphidinium, Procentrum, and Ostreopsis are all genera that produce the toxin. Now, exactly what is this toxin? Okay. So ciguatoxin, if you notice, this is a very large molecule. And if you notice also, there are many polyether moieties here. And there are several variants depending on the molecules that are attached to it. The nature of ciguatoxin is that it has a very low LD50 in mice of 30 micrograms per kilogram. It is heat stable, so even if you cook the fish, it will still remain poisonous. It is acid stable. It is lipid soluble and therefore has a tendency to hide in fatty tissue. And of course, when we talk about fatty tissue, we're talking about nerves and the brain. And like I said, it is a polyether compound. And this is something that we have to return to when we start talking about those cases, the few cases that can last for weeks to months to years. What is the mechanism of ciguatoxin? Well, it keeps sodium channels open in nerve, muscle, and cardiac cells. It blocks potassium channels. And of course, where you have sodium channels that are open and potassium channels that are blocked, then you have depolarization or partial depolarization of both nerves and muscle. And this will explain also the reason why you have the manifestations that we're going to be discussing later. There is repetitive action, potential firing, and one of the pathological findings in Ciguatera fish poisoning would be the swelling of the edema of the supportive Schwann cells on the axons. Ciguatera fish poison, the ciguatoxin also affects intracellular calcium, and this increase in intracellular calcium can cause an increase in gastrointestinal mucosal secretion, leading to diarrhea, or tetanic contractions in heart, skeletal, and smooth muscle, causing the cardiac and neuromuscular manifestations that we're going to be talking about in a while. There are paresthesias that occur in Ciguatera fish poisoning, and usually derangement in the type C polymodal nociceptive fibers are responsible for the pruritus that is encountered. And one of the characteristics of Ciguatera fish poisoning, not all cases will have this, but certainly a good number do, where there is a perception of hot-cold temperature reversal. So what feels hot feels cold, and what is actually cold feels hot. And this is because of the alpha delta, the A delta and the C fibers that have been impaired. There have been only a few studies on the toxicokinetics of ciguatoxin. Fortunately, we have one study of Pacific ciguatoxin 1 in a rat model. And here in this study, peak serum concentrations after oral ingestion was found after 2 hours. The half-life after oral injection was 82 hours. Ciguatoxin activity remained in the liver, muscle, and brain 96 hours after intraperitoneal and oral dosing. And elimination was primarily fecal, with a small fraction cleared by the renal route. The onset of symptoms is highly variable. It can be as short as 30 minutes to an hour post-ingestion, or it can be delayed up to 48 hours. However, most will manifest within 6 to 12 hours. Diarrhea is going to be lasting about 5 days on average, after which most cases will no longer be symptomatic. Okay. However, like I said, there will be some patients who will manifest longer. The clinical signs and symptoms are all consistent with the mechanism of action of partial depolarization and repetitive depolarization of the nerves and muscles. So for the neurologic symptoms, you have paresthesias, hot-cold sensory reversal, dysphagia, odontalgia, athetosis, ataxia, cholinergic excess. So it may actually be mistaken for organophosphate poisoning because of the blurred vision, hypersalivation, diaphoresis, lacrimation, tremor, and seizures. But while this is a list of possible symptoms, the most common symptoms really would be a feeling of tiredness, okay? A feeling of the description was of one of the patients whom I spoke to was it was like he had climbed a mountain, okay? And his muscles were feeling very, very tired, and that might also that might account for the ataxic gait that some of these patients will manifest with. The heart is affected because of it is a it is a cell that the myocardium undergoes depolarization. And so it can present as bradycardia and hypotension. And you have the gastrointestinal manifestations of diarrhea, vomiting, and abdominal cramps. Sometimes you can get deranged pro-time and partial thromboplastin time. Sometimes you can get increased serum ammonia levels, but mainly it's diarrhea, vomiting, and abdominal cramps. The dermatologic manifestations they do happen, but they don't happen that often. But when they do happen, okay, they will manifest as pruritus. This pruritus can be aggravated by ethanol use. There can be urticaria. There can be bullous or these squamating lesions. There are interesting obstetric and gynecologic symptoms. There were case reports of dyspareunia in wives of male patients, so that when they would have intercourse, then there would be a pain that the wife experiences, suggestive of possible seminal transmission. There were reports of abnormal fetal movements for women who were pregnant who developed Ciguatera fish poisoning. And this is suggestive of transplacental transmission. It is not known to be teratogenic. Now, for the cases I said of that subset of patients where the symptoms last longer than the usual 5 or 6 days, these chronic effects often involve protracted pruritus, weakness, hiccups, hypertension, and paresthesias. These effects may persist for months and even years. They may resolve and suddenly reappear under stressful periods or after vigorous exercise. On top of that, exposure to polyether moieties can cause recurrence of the acute symptoms, particularly the hypotension or the hypertension. We have to emphasize that Ciguatera is a clinical diagnosis. There is no diagnostic test that can be done on the human to make the diagnosis. There are tests, however, to determine ciguatoxin in the fish that was eaten, assuming that you're still able to get a specimen of it. However, the determination of ciguatoxin in the fish meal associated with symptoms, the results usually come several days after and are not useful in the initial treatment of the patient. Therefore, it is, you make that diagnosis and then you treat accordingly based on clinical grounds. And the laboratories that you will be asking for will depend on the manifestations and the complications that you encounter. What is the treatment of Ciguatera fish poisoning? Acutely, you have to stabilize the patient by ensuring patent airway and breathing in the few cases where you can have respiratory depression. Be prepared to do mechanical ventilation when needed. Although, like I said, this is something that happens quite rarely. Maintain adequate circulation with intravenous isotonic fluids. Correct fluid and electrolyte deficits. If there is hypotension, then give your pressors. And if there is bradycardia, you can give atropine. After stabilizing the patient, then if in the rare occasion that you are able to catch the patient within an hour or two after he ingested the fish, and there may still be some offending fish meal in the gut, then you insert your nasogastric tube, you give your activated charcoal and sodium sulfate. But this rarely occurs. Most of the time, our patient will be coming in hours after having taken the fish. And there really isn't very much to decontaminate. There's this interesting maneuver involving 20% mannitol. Okay, you can give it at 1 gram per kilogram intravenous after correcting fluid electrolyte imbalances. And you may consider a second dose if the patient still has symptoms 24 hours later. Mannitol has to be explained a little bit. It was discovered serendipitously when there were these two Polynesian natives who presented with, later on, the assessment was severe Ciguatera fish poisoning, but their initial presentation was that of coma, acute coma, and therefore the assessment was an intracranial bleed. And because there was no hospital in the island that was sophisticated enough to handle their case of intracranial bleed, they were flown to a bigger island with a better hospital. And in between, while they were on the plane, they were given mannitol. When they arrived in the island, they walked off the plane on their own power. They had recovered, no? And this was the beginning of all of these observational studies on the use of mannitol. It's not clear what the mechanism is, why mannitol works. It's possible that mannitol can decrease the Schwann cell edema. Yeah. It's possible that its ability to scavenge hydroxyl radicals is helpful because of this polyether moiety that is ciguatoxin. Most of the studies are case series and case reports. There was one of only two randomized controlled trials, and it was back in 2002 with only 50 subjects that did not show any advantage over normal saline at 24 hours. However, because of the plethora of case reports and case series that show that mannitol seems to work in certain cases, then it is something that is worth considering to give to a patient. There has been no experience of mannitol with children younger than 6 years old. So it's not certain whether mannitol can be given to children. Subsequent treatment is supportive. If the patient has seizures, then you can give diazepam. If there's cholinergic excess, you give atropine. If there's proton derangement, you can give vitamin K. And if there is persistent paresthesia, amitriptyline and gabapentin have been tried in order to be able to handle those paresthesias. And after that, it's important, because of the possible recurrence of symptoms, to avoid substances with polycyclic ether moieties for at least 3 to 6 months. What are these substances? You have alcoholic beverages, nuts or nut products, shellfish, fish, seeds or seed products, mayonnaise, cosmetics, ethers, glues, epoxies, resins, solvents, insecticides, barbiturates, opiates, and marijuana. And all of these have been known to trigger a recurrence of symptoms. It's also important to avoid vigorous exercise in order to prevent a recurrence of symptoms. For travelers, these are some practical guidelines that can be used in order to prevent yourself from getting Ciguatera fish poisoning. Don't eat big reef fish. 2 kilograms or more seems to be the critical weight. Don't eat fish considered harmful by the locals. Don't eat scaleless fish or moray eel. Don't eat the liver, the head, the gonads, eggs, viscera of any marine fish, because this is where the ciguatoxin likes to hide in the lipid-rich organs. Don't eat fish after there has been a disturbance of the reef environment, because there'll be dead coral there. Don't eat fish caught in the windward side of the islands, because there's a lot of turbulence there, and therefore, again, a lot of dead coral. However, okay, there is a bigger problem than just preventing it for travelers. We go back to dead coral as the starting point of a toxic reef. And right now, reefs are being destroyed by human dredging to be able to create artificial islands, by cyanide fishing, by dynamite fishing. And on top of these human activities that destroy fish, there is also the phenomenon of increasing sea surface temperatures over time, associated probably with global warming. And there have been 4 global coral bleaching events devastating coral reefs because of these increased sea surface temperatures. There was one in 1998, another in 2010, another in 2017, another, and the latest one started 2023 and up to 2024. Note that the darker shades of orange and red are the areas where you have high sea surface temperatures in a sustained manner associated with the coral bleaching. And take note that there is an increasing trend of surface sea temperatures over those 4 global coral bleaching events. Note also that the intervals between coral bleaching events seems to be getting shorter. The latest coral bleaching event, 2023-2024, okay, involved the countries of Kenya, Australia here, Panama here in Central America, and Brazil. And if you want to know what are the hotspots right now, where sea surface temperatures are high, this one is the latest picture, okay, where you have in these areas that are characterized by dark orange or red areas where the sea surface temperatures are very high. And where you have the orange or light yellow, then these are areas which bears watching. So I think that because of these trends, we can expect more cases in the near future. And certainly beyond just avoiding Ciguatera fish poisoning for travelers, it's important for us to save the reefs. And we need to stop fishing practices that destroy the reefs. We need to stop the dredging of reefs to create artificial islands, which means that we have to be able to find a solution for the global conflicts that cause this dredging. And finally, we have to mitigate global warming. So thank you for your attention.
Thank you, Dr. Dionisio, for that informative talk. Again, a reminder, please post any questions you have in the Q&A section. We will address them during the forum session. We will now take a 30-minute break. Please feel free to take this time to stretch and grab a refreshment. We will resume at 10:15 a.m. In the meantime, I would like to take this opportunity to promote an exciting upcoming event, the 22nd Scientific Congress of the Asia Pacific Association of Medical Toxicology, APMT 2024, which will be held at G Hotel Gurney, Penang on 11 to 14 November 2024. This event promises a stimulating and thought-provoking experience featuring leading experts in medical toxicology from across the Asia Pacific region. All registrations will close on 18 October, so please make sure to secure your spot before this deadline. For any queries, you can reach out to the conference official email at apmtmalaysia@usm.my. We hope to see many of you there. We will reconvene shortly for our next presentation. Thank you. Now, but again, if you will start again, a quick reminder, Please post any questions you have in the Q&A section. We will answer them during the forum session at the end. Okay, again, welcome back everyone. Our final speaker is Dr. Randy Zainubun, an emergency medicine consultant from Esnawan Antariksa, Indonesian Air Force Hospital in Jakarta. Dr. Randy is also the head of ENA at Triadipa Hospital and has held many leadership roles across different hospitals in Indonesia. In addition, he has authored several publications in the field of emergency medicine as well. Dr. Randy's presentation today will focus on the effect of magic mushroom, psilocybin in Indonesian adult male, which is an emerging area of interest given the increasing use of psychedelics. Let's welcome Dr. Randy Zainubun.
Okay, thank you. Good morning, everybody, dear colleagues. Okay, and let me discuss something easier, maybe, because usually we don't need special treatment or special confirmatory test to diagnose magic mushroom. Okay, everybody, do you ever heard about film that is called Alice in Wonderland? How many of you has watched the film Alice in the Wonderland? If you watch it carefully, there's a scene that show Alice, the little Alice, ate a mushroom, and after that, he feel out of body experience, and you can see that her body is become smaller. That is why something that we know Alice in Wonderland syndrome, the psychiatry said sometimes. Okay, we start. Okay, let's talk about psilocybin poisoning. Okay, my name is Randy. And now let's go straight to our case. We have two patients, guys, Mr. N and Mr. B. Mr. N and Mr. B is found by their roommates with 1 hour crying and laughing so hard. So when the roommates hear about it, they come to Mr. A and Mr. B room. And then they find that there is 2 bowls of instant noodle and 2 cups of coffee in the room. The first bowl is almost empty and the second one is half full. And both of the coffee cup are empty with a little powder in the bottom. And what's interesting is they also find that there is a little open pack white natural substance in the table, and the roommates think that it looks like magic mushroom. And then they both arrive to our ED in about 1 hour later. Mr. A can walk, yelling and crying. Within an hour after arrival, Mr. A was discharged well after 2 days. And Mr. B's symptoms didn't progress and was discharged after hours observation in ED. So let's go straight to Mr. A. Mr. A has a normal vital sign, and what is funny that he said that he saw a full train go crossing his room. And then he saw his girlfriend is operated in the OR. He said it to us. He feels sad and anxiety, so he's crying. He also said that he had lightheadedness and nausea, and he didn't know what is he right now. So he has a place disorientation. Wow. How about Mr. B? Mr. B also have a normal vital sign, and he said that he is a Gatot Kaca. Gatot Kaca is an Indonesian traditional hero, a wayang that can fly and has a strong body. And Mr. B said that he is a Gatot Kaca and he is flying to his house in Mojokerto. Mojokerto is in East Java. It's about 600 kilometers from Jakarta. Mr. B feel happy and laughing all the times. But he is confused when he know that he was on ED because he think that he is flying to his house. So Mr. B didn't have a place disorientation. The objective of this presentation is, the first, we have to identify causes of natural substances poisoning. And then we'll discuss on presentation and clinical management of natural substances poisoning caused by psilocybin. And also we have to highlight the importance of prevention. So the introduction of this presentation is, let's suspect natural substance poisoning. If people get sick after taking something like herb or natural substance, and magic mushroom now is more likely because the user feel that mushroom is harmless than drugs, than the other drugs like meth or amphetamine or synthetic nicotine. In Indonesia, we call it tembakau gorilla. And many people use magic mushroom as a recreational purpose or religion experiences. We have 14 genus of mushroom. The first is Amanita phalloides. The symbiotic is cyclopeptides. Mortality is less than 30%. The second is Geromitra ambigua. Symbiotic is gerometrin. Mortality is rare. The third is Cyclobite delabata. Xenobiotic is muscarine. Mortality is rare. Next is Coprinus altamentarius. Xenobiotic is coprin. Mortality is rare. And the next is Amanita gemata. Xenobiotic is ibotenic acid and mucimol. Mortality is rare. What's interesting about Amanita gemata and Ebutenecas mucimol, this mushroom is also show the hallucinogenic effect for the user. Yeah, so this is the same with what we discuss now. The 6th genus, Psilocybe-Chirolepus, Xenobiotic psilocybin and psilocin, mortality is rare. So both of the genus in the number 5 and number 6 show the hallucination effect. The 7th genus is Cladrecipe nebularis, Xenobioticus varius, mortality is rare. And next genus is Cortinarius olearus, Xenobioticus oralin and oralanin, mortality is rare. Next genus is Amanita smithiana, Xenobioticus Allan ignorescens, mortality is rare known. The next is genus Tricoloma equestre, Xenobiotic unidentified, metexin, mortality is 25%. Next is Cletosclype acromeralga, Xenobioticus acromelic acid, mortality is known. And this is the highest mortality mushroom. Plerosibella porigens, unknown, has a 30% mortality. Next is Bacillus involutus, Xenobiotic, immune-mediated response to involutus, mortality is rare. And the last one is Lycoperdon perlatum, Xenobiotic spores, and mortality is rare. Next, we will discuss about the history of magic mushroom. It commonly used in North and South Americans' religious experiences and is popular because of the hallucinogenic effect. I don't know why, but most of the user is looking for the hallucinogenic effect. And what is interesting, because the hallucinogenic effect, it depends on the personal life experience of the user. So it depends on the personal life experience of the user. If they had a sad experience in their life, so they will cry. If they have a happy life experience, so they will always laughing if they use magic mushroom. Magic mushroom produce CNS effects rapidly in about 1 hour, including ataxia, hyperkinesis, visual illusions, and hallucination. And anxiety and lightheadedness develop rapidly. And all of the symptoms return to normally between 6 to 12 hours. In Indonesia, we call magic mushroom in slang word, we call it mas air or samram or jamur tahi sapi. In Malaysia, please correct me if I'm wrong, they call it dadah mushroom. And magic mushroom is popular among the user because they say that mushroom is cheaper and less fatal than drugs. Like I thought before, they think that it's less fatal than meth or coke or amphetamine or something famous in Indonesia right now is synthetic nicotine, and we call it tembakau gorilla in Indonesia. And the method of use magic mushroom in Indonesia, they cook it with instant noodles like Indomie. and they mix it with hot coffee. This is the, we can see the picture. So they make the coffee, they boil water. So in the hot water, they put the magic mushroom and they put it in a cup of coffee and they drink it. Magic mushroom primary active compound is psilocybin, and they affect the brain by enhances serotonin receptor activity. The short-term effect of psilocybin is anxiety, panic disorder, mood swing, and the common effect that the user always looking for is hallucination and visual illusions. The onset is about 30 to 60 minutes, and the duration is 6 to 12 hours. So how we diagnose the psilocybin poisoning? Like I told the first, there is no confirmatory test to diagnose this. We can always diagnose from the history taking. What is interesting is the user always say to us, they didn't shy, and they always, sometimes they admit and they say to us, Doc, I ate magic mushroom last night. Doc, I ate magic mushroom 1 hour before. So it is different from the other user that use the other drugs like meth or amphetamine, coke. They always refuse that they use the drugs. But magic mushroom users usually say to us that they use magic mushroom before. And the signs and symptoms is interesting because they always have hallucination and visual illusions. Okay, we have to diagnose this with confused after use the other drugs or after taking alcohol. And there is no confirmatory test need to diagnose psilocybin poisoning. The management is always supportive and symptomatic. It's just about 0.2% magic mushroom user need a special treatment. Sometimes we use benzodiazepines to reduce the ataxic effect, and there is no antidotes and no diagnostic tests, but we need to observation or monitor the patient because when the patient still have hallucination effect, so there is a chance that the patient won't or can self-harm. If they think that they are a Superman and they fly, if they are in the second or third floor, they can suddenly jump to the ground. Or if they use the magic mushroom in the pool area, if they think that they are a fish in the hallucination, they can suddenly jump to the pool. Okay, so we need to observation the magic mushroom or psilocybin poisoning patient. An advanced life support intensive care in severe case. And the primary prevention is we have to avoid eating and drinking substance like magic mushroom and also risk communication. The secondary prevention is notification and risk communication also. And this is the magic mushroom poisoning summary. We can always diagnose the magic mushroom poisoning from history taking, eating magic mushroom. And the symptom is visual illusion and hallucination. Like Mr. A, he looked trained in the room. And they always have mood swing. Sometimes they're laughing and crying. But the vital sign is usually normal. The management is ABC and symptomatic. And we have to observation the patient to avoid him or her from self-harm. Okay, I think this is my presentation. Hope you can enjoy it. Thank you and have a nice day, colleagues. Thank you.
Thank you, Dr. Randy, for that fascinating presentation. Okay, we will proceed. We will now proceed to the forum and Q&A session. Okay, I think because the other presenter might be not ready yet, but we have Dr. Randy here. Dr. Randy, can we proceed with question first, Dr. Randy?
Okay.
Sure, thank you
That's
so much.
good. Okay.
So there's a question from the participant. The first question for Dr. Randy is, in the case of a magic mushroom ingestion, is there any point of care test that can be tested to be confirmed that is ingestion of the magic mushroom, like urine tox or urine drug?
Yeah.
Any
Yeah.
of that? Okay.
Okay.
Thank you.
Thank you. Nice question, Dr. Sofina Zainal. Unfortunately, in Indonesia, we just have 6 parameter for urine test, and there is no special for magic mushroom ingestion or psilocybin. The 6 parameter is just coke or meth or amphetamine or benzodiazepine. Yeah. So there is no special urine test for magic mushroom or psilocybin. The next question is, in the case of magic mushroom ingestion, is there any interaction with any drugs or alcohol that can enhance the hallucinogenic effect? Absolutely, Doctor. Because the alcohol and the other drugs can enhance the hallucinogenic effect too. And what is important that we have to always think that the patient that use magic mushroom, they will use it with alcohol together, or they will use it with any other drugs like diazepam or nitrazepam or the other drug. So we have to always think that the magic mushroom user use it or take it with the other drugs together. So we have to be more careful. What is the minimum dose that can produce the hallucinogenic effect? Thank you, doctor. This is the nice question. What I've read the journal about psilocybin and magic mushroom, there is no minimum dose to produce the hallucinogenic effect, but it depends on if we use magic mushroom regularly or if we always use it every week or every day, because we can find magic mushroom easily. Yeah, in Indonesia, we can find the mushroom in a farm, in a cow farm, and yeah, they use and they cook it in their house. So sometimes, yeah, in the village, they maybe use it regularly, but I didn't say it. But because it is easy to find it, and they feel the hallucination effect is happy, so they use it. So the minimum dose, I just read the URL, there's no minimum dose because sometimes they cut the mushroom, so langsung they put it and then langsung ate it. So I just read the journal that there is the minimum dose that can produce the hallucinogenic effect. It depends on the person who ate it. Thank you.
Sound? Okay, thank you so much, Dr. Dr. Randy for the thorough answer and sharing expertise. Dr. Choo is here. Dr. Choo, ready for the answer for the questions?
Yep.
Thank you so much, Dr. Choo.
So
So we have
for
a
the
very interesting question from the floor, that what is the treatment for STEMI, for the STEMI following the snake bite? Is it antivenom only, or we can give together thrombolysis? So the floor is yours.
okay. So first, because as mentioned just now, MI in cobra in snake bite is not a common occasion. So if you see a STEMI, of course, it's associated with snake bite. First, whether the snake bite identified or not identified. Because if it's non-venomous snake, then the MI is most really not because of the snake bite. So first is ensure that the MI is due to thrombosis or is due to the snake bite. But of course, sometimes it's difficult because to confirm is due to thrombosis, you need coronary angiography for confirmation. But let's say if the patient is young patient, like never have any illness, is a 20 years old and healthy adult. In that case, then snake bite envenomation is the most likely cause. Then anti-venom will be the priority treatment to neutralize the venom to prevent further damage. The thrombolysis is generally not recommended, I would say, because it's not the main culprit, not the cause. Unless there's a so thrombolysis is only indicated if there's clear thrombotic cause of STEMI, which will require diagnostic confirmation. So anti-venom is still the primary treatment. Okay.
Okay, thank you, Dr. Choo. I have another question for Dr. Randy, but I go straight to another question for the Dr. Choo first, which is the second question, also from our participants. How many vials of antivenom to give in cardiac arrest, and how fast do you give? Let's say patient datang dah already cardiac arrest and with a history of a snake bite, kan? So should we give antivenom that time, and how many vials is it?
Okay.
Thank you, Doctor.
Because snake bite is the antivenom is species specific. And even for polyvalent, it's also targeted certain species. So first, as mentioned, it's like you want to say you have to confirm that it is a venomous snake that have cardiotoxicity. If you are bitten by, let's say, crab, there is no cardiotoxicity, but the patient came with cardiac arrest, then most likely it's because of respiratory arrest, because of neurotoxicity, neuroparalysis, then lead to respiratory paralysis and respiratory arrest. So in that case, the culprit of the arrest is actually the hypoxia. Of course, antivenom is important, but antivenom is for the neuro part. So we don't have a general guide saying that if you see a patient history, the snake bite come in BID, brought in that, you want to give antivenom. What antivenom you want to give? If you don't know the snake. So we cannot just simply just dump in any antivenom that we want. Unless you are clear that which venom, let's say it's really a cardiotoxic agent, like Naja or anything. Even so also, like let's say you know the species, then you can give. If you don't know the species, I will say you just proceed with the ACLS protocol first, according to ACLS protocol first, unless you are sure what species you are dealing with. If you are not sure, the antivenom you might cause more harm than good. If you are confirmed that the patient is deal with certain species of snake, venomous snake, and there is an antivenom available towards that venomous snake, then you can give. Of course, in this case, you don't have to give slow over 1 hour. You can give it as fast as you want. It's just like when you give amiodarone for VF and amiodarone for other types of SVT, VT, is different dose, is different method, right? For amiodarone in VF, you give 300 milligram bolus. But if you are given for other type of tachyarrhythmias, you are giving over certain period of time, 15 to 30 minutes. So in cardiac arrest, you can give it fast. Just give it fast bolus. If you are sure what you are dealing with, just give it fast.
Thank you, Dr. Choo. That's very interesting insight. But one of our colleague also asking if, let's say, we already confirm or identified the species of the snake, might you might share the doses that or the vials of the antivenom that we might use. Thank you, Doctor.
Okay, in Malaysia, if you are dealing in Malaysia, we follow the MOH guideline. It's systemic envenomation, because if local envenomation, you won't suddenly cardiac arrest. So it's definitely you are dealing with systemic envenomation, whether it is cardiotoxicity or because of neurotoxicity leading to paralysis, respiratory paralysis and respiratory arrest, is all under systemic envenomation. Follow the guideline, follow the systemic envenomation doses. So for Malaysia, the MOH guideline for our antivenom, we are giving 10 vials for Naja NKV and neuropolyvalent if you are dealing with other neuro, because not all the center have the specific CRAC antivenom. So for CRAC, you might need to use NPAV, neuropolyvalent, so it's 10 vials. So they just follow our MOH guideline. There's a guideline there, we just follow it.
Thank you so much, Dr. Choo. We have another about 1 or 2 questions for Dr. Choo, but we go back to Dr. Randy. Dr. Randy, okay, Doctor? So
Yeah.
we have a question for Dr. Randy regarding the psilocybin. So
Yeah.
how should the ED approach the initial management of a patient presenting with acute psilocybin intoxication? Usually they will come with a severe agitation, hallucination. What our steps, critical step to our ED colleague to take it? Thank you.
Okay. For sure, the first is we have the ABC. Okay. So, and then we can give your symptomatic treatment. And like I said before, we have to observe patient. We have to observe the patient, yeah, because they can self-harm. So, first is ABC, and then symptomatic. Then we have to observe the patient from reducing to self-harm. Yeah.
Okay,
Thank
thank you,
you.
Dr. Randy.
Yeah.
Okay, thank you so much. Actually, we're still waiting for another panelist, which is Dr. Allan. He now is ongoing some program, even in other place. But we have a question also to Dr. Choo. Actually, when we go through to the Q&A section, actually it's almost the same. It's basically if we are in a place that we don't have available antivenom, and we have a patient that came in with cardiotoxicity, or perhaps not just a cardiotoxicity, what the alternative ED strategies that we can take it in case of our center don't have the available antivenom, Dr. Chu?
Okay. First, it depends on how your center and the tertiary center deal with it. If your center is a bit well equipped, you can do close monitoring. You have a bit of like high dependency unit HDU service. You may not need to send your patient to the tertiary center, but in fact, the tertiary center may be able to just transfer the antivenom to your hospital for you to administer, to stand by. But if your center is really a very rural district hospital that cannot support a close monitoring, or in case anything's deterioration happen, you cannot cope with it, then it's better to send to a tertiary center.
That's a very good advice and strategy from Dr. Chu, because it's much safer to we send the antivenom despite when we send the patient that are not stable. We have another question, but it's really an open question. How about allergy reaction? Is it related to the poisoning? I think better I direct it to the Dr. Randy. Dr. Randy, there's a question for the participant. How about allergic reaction? Is it related to the poisoning? Thank you, Doctor. Actually, very general this question. Thank you, Doctor.
Okay, thank you. To be honest, I never met the psilocybin poisoning with allergic reaction, because there is the patient that come to our ED, they are a regularly user, yeah. But about the question, I think maybe there is a chance that the psilocybin poisoning can also have allergy reaction also. And so we have to treat it with symptomatic treatment, yeah, for allergy reaction. But to be honest, I never met patient that ate that magic mushroom and they come with allergic reaction. Thank you.
Thank you so much, Dr. Randy, for being with us with this answer and so on. Dr. Chu, we have another question. Actually, it's related, almost the same. Let's say we have a patient with a known case of a AF or some by Germany, PVC or anything, and then got bitten by the snake. And then we suspected it will cause the cardiotoxicity by the new changes in ECG and all. But memang known case of a IHD or something. How do we differentiate? Is it just a baseline of the patient, or is it something related to the cardiotoxicity, Doctor? Sorry, Dr. Chu. Dr. Chu, not yet.
Sorry, I
unmute.
forgot to
Okay,
unmute.
thank you, Doctor.
Okay.
Sorry.
So this is like a tricky question, that because the patient has underlying heart problem. So you can take it like you are treating a post-MI patient. Let's say you have a post-SCS patient that come to you. So what you want to do? You see the ECG, there is a Q wave with ST elevation. So is it a new one or is it due to previous insult? You don't know, right? You need baseline. Then even if there's baseline similar, you still want to monitor, you still will take troponin, etc., right? So it's the same thing. If the patient has underlying AF and bitten by the snake, and now the monitor show AF, so it's difficult for you. So of course, this is the baseline, but if there's new changes, let's say you see a new ST changes or you new PVC, etc., it can be due to cardiotoxicity, but it also can be due to other causes because the patient is panic at that time or having some autonomic dysfunction also because of snake bite. So there are a lot of things that you need to think of. So the main thing is still close monitoring. You have to close monitor, especially hemodynamic. If it affects hemodynamic and there's no other insult that you can think of, is unlikely due to a new SCS, etc. It's just a snake bite. Then after that have hemodynamic instability, then most likely is due to the snake bite. But if the patient is stable, then it's very tricky. You just need to close monitor and see what will happen next. Then how long should monitor? So it's just like all the snake bite, we recommend to monitor at least 12 to 24 hours. Then at the meantime, you may need to take serial troponin and also watch out for neurotoxicity. Because as mentioned just now, cardiotoxicity, although is rare itself, and most of the time it will be follow after neurotoxicity. Although there are some cases that only cardiotoxicity, but it is super rare. So it might not happen to you so often. The more often one will be neurotoxicity together with cardiotoxicity. So if you see that, just close monitor. If any point of time that there is hemodynamic unstable or neurotoxicity set in, then you know that you need to give antivenom.
Thank you so much, Dr. Choo and also Dr. Randy, for your detailed explanation on each of topic. Both of your expertise on both of the topics is highly valuable, and we appreciate your time in answering these questions. So for time being, there's no more questions that we can proceed with this forum. So while waiting for the Dr. Allan to be available with us, for the participant, we will proceed with the Kahoot session. Okay, so Dr. Randy and Dr. Choo, thank you so much from our side. Thank you for being with us with your all the explanation shared to us. Also for the participants, we will proceed with a fun and interactive session, iaitu our Kahoot quiz. Okay, so our technical team will show the QR code. So you can join by scanning the QR code on the screen or by entering the code in the chat. Let's test what we have learned in a relaxed way. And after the Kahoot, we will meet again, we convene again for the questions session with Dr. Allan. Okay, the Kahoot will be ready in 5 minutes. So please be patient and be with us. So within the 5 minutes, we will share the QR code and the instruction. Okay, thank you. All right, we shall start now. Dr. Allan might join with us. We can switch on the video and also the audio. And congratulations again to Kamal, our participant that the champion for the Kahoot session. Thank you again, Dr. Allan, for being here with us. So we now proceed to the Q&A session with Dr. Allan. There's a few questions regarding the Ciguatera fish poisoning from the floor. And the first one is regarding, since there is no antidote for the Ciguatera fish poisoning, how should us, the ED colleague, to manage the severe cases, especially those involving the cardiovascular complications such as bradycardia or hypertension, doctor?
Yeah. Before I answer the question, am I coming in clearly?
Yes, doctor.
Okay.
Loud and clear.
Yes. Yes. Well, regarding the absence of a clear antidote for Ciguatera fish poisoning, like I mentioned, we have these case series and limited randomized control trials for the use of mannitol, no? For acute Ciguatera fish poisoning. And I guess the best we can say is it's worth a try. No? If it works, it works. If it doesn't work, then we go supportive management and we treat the complications as they arise. Or alternatively, maybe the better thing to do would be to anticipate so that we are ready to handle them if they do arise. No? For the most part, for Ciguatera, like in the lecture, every covers the whole range of possible complications for Ciguatera. But the fact of the matter is most cases of Ciguatera will manifest with just a few of those gamut of symptoms. Diarrhea, therefore some dehydration, muscle weakness, paresthesias, and most of them can actually be handled in a primary or secondary care hospital facility. No? So, and then like I said, mannitol can be tried, and if it works, then we're happy. If it doesn't work, then we still go the usual route of supportive care.
Thank you so much for the insightful answer, Dr. Allan. Because we don't have a point of care test to confirm that this is Ciguatera poisoning. So what are the key symptoms that should we in the ED be prioritized in the ED when assessing a patient suspected of having Ciguatera fish poisoning? How would you approach their management? Thank you, doctor.
Well, example, the patient has some gastrointestinal symptoms plus neurologic symptoms like paresthesia, for instance, after eating a big reef fish. Okay, or actually after eating a reef fish, or then you think right away of Ciguatera fish poisoning. And that criterion of having eaten a fish from a coral reef is a very important criterion because, like for example, for shellfish poisoning, it's very clear what the organism is, no, what the vector is. So if you eat shellfish, then it's probably paralytic shellfish poisoning. But if it's reef fish, big, then it's probably Ciguatera.
Okay. Thank you. Thank you so much, Dr. Allan. The next question is from the participant. Hi, Dr. Allan. For ciguatoxin, the elimination is primarily fecal and with a small fraction cleared by the renal route. So, is it meaning that the diarrhea is good for the patient and we just need to support the patient in hydration? Am I right? And does hemodialysis have any role in treating those patients who presented with coma or severe toxic? Thank you.
Okay, those are two questions. So I guess the first one would be, as I understand it correctly, is diarrhea helpful? No? And therefore just let him have his diarrhea and then after treat his dehydration, electrolyte imbalances. The answer is, well, yes and no. Okay. Yes, because the diarrhea is able to somehow sweep away whatever offending fish material is present. Okay. But know also that the diarrhea itself is a consequence of the mechanism of action of the ciguatoxin. That is, and so I think that uh, uh, paying attention to the fluid balance and paying attention to the electrolytes would be central in the management of the diarrhea. Regarding the question about hemodialysis, no, I don't think there's any role for hemodialysis in Ciguatera fish poisoning, unless because of the severe dehydration, the patient develops acute renal failure, which of course I think is going to happen very rarely, although theoretically it could happen. Ciguatoxin is highly lipophilic, and because of that, you're not going to find very much of it in the blood. No? That is in dialyzable amounts.
Thank you so much, Dr. Allan, for your detailed explanations. Your expertise on the Ciguatera fish poisoning is highly valuable, and we are really appreciate your time in answering this question. I think from the floor and from our team, there's no more other questions, and we will proceed with the closing remark. But before that, Dr. Allan, do you have anything to add on as a for the end of the session? Anything?
Well, a couple of things. I guess the first one is that I was unable to properly give credit to the source of my figures, no? And for those of you who are interested in taking a look at the graphs of the National Oceanic and Atmospheric Administration, or NOAA, okay, the pictures of how they monitor surface sea temperatures are there at their website. Okay, so that's one. The other one is that, like I said, Ciguatera fish poisoning happens sporadically. At least here in the Philippines, it does. Now, I suspect it probably happens sporadically also in other places. But we really have to watch out because of the pattern of increasing sea surface temperatures and the increasing amount, in the increasing incidence of coral bleaching. Wherever there is dead coral, we have to watch out for the possibility that Ciguatera fish poison outbreaks are going to be present.
Thank you again. Thank you so much, Dr. Allan, for your sharing. We are really appreciating your expertise. So we are at the end. We are going to go to the closing remarks. Thank you, Dr. Allan. Thank you so much.
Okay, thank you. Thank you for
Thank
inviting.
you. So to close today's session, we are honored to have Professor Dr. Ahmad Khaldun Ismail, an associate professor and consultant emergency physician at University Kebangsaan Malaysia UKM. He specializes in clinical toxinology, emergency medicine, and pre-hospital care. He is actively involved in international toxinology organization and serve on various advisor boards, including the WHO's global roster of experts for snakebite envenoming. Professor Khaldun has published numerous papers and holds honorary position in toxinology societies across Asia. Please welcome Prof. Dr. Khaldun for the closing remark.
Assalamualaikum warahmatullahi wabarakatuh. Very good morning to everyone. Thank you for the great input from all of our panelists, and I think very engaging Q&A session. I hope all our participants who are here today will continue to support our program. And for those who missed the first week of our EMSS this year, I have already shared the link to the recording on YouTube. You can go and view those recording, and we will actually also put up the recording on YouTube for this week's session. So with that, I would like to again say thank you to the team, thank you to our panelists, and thank you all participants for your kind support. And I hope everybody gain valuable input and also updates from our discussion today. So with that, I wish everyone a very good day. Thank you.
Thank you, Prof. Dr. Khaldun. Thank you again to all our amazing speakers for sharing their expertise, and to all of you for attending and participating. We hope today's webinar has been informative and beneficial for your practice. A big thank you to our organizers and collaborators who made this event possible. Please, again, don't forget to fill out the feedback form to claim your e-certificate and CPD points. The feedback form will remain available until 3 p.m. local Malaysia time. And for our Kahoot winner, don't forget to message Dr. Winnie to claim your prize. Until next time, stay safe and have a wonderful day ahead. Thank you. Assalamualaikum.